Well, today we're going to talk about cancer immunotherapy. Why is this such a hot and important topic? Well, firstly, the first thing that always comes out of most people's mouth when they meet me and other medical oncologists, can't I just let my immune system take care of the cancer? Is there a way we could do this naturally? And so the answer is yes and no. And through this talk, I'm going to do a little bit of teaching, and we're going to see how our immune system actually does help us and how we help the immune system to help us some more. All right? But in order to do this, I need to give you a fair basic idea of how our immune system works and then how it works in relation to cancer, okay? So bear with me on the first part. So we're going to talk a little bit of an overview of the immune system itself, what it is and how it works. Then we're going to talk about different ways we can tackle this immunotherapy thing, different modalities, because it actually comes in much different forms as you learn. We'll talk about immunotherapy for breast cancer. We'll talk about immunotherapy for colon cancer. We'll also talk about immunotherapy for kidney cancers. Now, I picked those three just because there's published information on those already. But as Jessica pointed out, this is becoming a really hot topic all over the place. And even in other cancer types, we're kind of learning how to use the immune system a little bit better. And so we're going to talk about the future directions for immunotherapy and beyond. So what's cancer immunotherapy? So it's basically what we're going to do is it's treatment basically to let the immune system help us fight cancer, okay? We can do it in a couple of different ways, and we already have started to do that. We can stimulate the immune system to work harder and smarter to fight cancer cells. So we can give you man-made immune system proteins, so we can learn from the body, right? So you might hear this whole immunotherapy in a different form. People sometimes call it biological therapy or biotherapy. Many different names, but basically it's the same concept. Get the immune system to do what you need it to do. So, what's our immune system? Well, its primary focus is pretty clear. It's basically our defense mechanism. Our defense mechanism both inside and outside the body, all right? So we have a couple of things that we're born with that's part of our immune system. Our skin, our saliva, our stomach, the pH in our stomach, those are things that we're born with, and that's actually all a part of our immune system. So, but the thing about our immune system is it needs to be able to do a lot of different things, and not just do it, but do it quickly and know when to go up and also know when to go down. Because nobody ever thinks, oh, I have a bacteria in my body, I need to do more stuff. Our immune system does that for us automatically. We don't have to think about it. So one of the key points I want to point out is the immune system has to learn. We come into this world as babies, and we're exposed to a number of things. And then as we get older, we get exposed to even more things. All right? So our immune system has to be able to learn. And it has to be able to adapt and respond quickly. All right? And when we interrupt the ability to adapt and respond quickly, that's when we have real problems, right? Because if your immune system can't adapt to a new bacteria or a new virus, then the virus can overwhelm you, okay? It also needs, and this is an important point, it needs to be able to recognize alien, which means that shouldn't be there, from normal tissue, right? Or normal things that should be there. Because we have some bacteria that live inside our bodies that are supposed to be there that help us as human beings to keep bad bacteria away. And it has to be able to regulate itself. Basically, it has to be able to turn itself off, all right? It also has to be able to recognize normal from abnormal. So our immune system is basically divided in two broad categories, which is innate, which is basically means our natural immune system, the one we're born with. And then there's what we call an adaptive immunity, all right? Now, can anybody think of what's an example of an adaptive immunity where the immune system actually learns something? We've all done it. We've all had it done even when we were babies. Right, immunization, right? So when we get vaccinated, what we're doing is we're teaching the immune system. And we're teaching the immune system to recognize something as foreign. So these are the different ways we can teach the immune system, right? We can naturally get an infection. If we get an infection, we see a bacteria one time, we can create an immune response. That's natural. Artificial is the vaccination, right? And then this is the reason why breastfeeding is so important. This is called passive immunity. We can actually women actually give antibodies, an immune protection to their babies by breastfeeding, right? And that's why the longer kids are breastfed, the healthier they are over the long haul. So this is another big plug for immunity. And then this is called artificial immunity, where we give antibodies from other people who had an infection. We give it to the person who has an infection, whose immune system may not have caught up to it. And that way we can protect ourselves. Now you guys remember probably last year sometime when they had the Ebola infection and everybody was getting sick and then the nurse got sick at the hospital. Well, one of the things they did to help her get over an infection is the doctor who had gotten sick months before, he developed an immunity to it. So they took his blood, which had these antibodies, and they gave it to the people that he was able to donate to, and that's what we call an artificial immunity. So even though her immune system couldn't do it, he'd already developed an immunity, so they were able to use that antibody. So that's a different way of a passive immunity. All right, so adaptive immunity. This is the more specialized one. This is where the immune system learns. And how does it do it, right? So what happens is, everybody knows from the high school biology days, white cells, macrophages. It comes in and finds a bacteria. You chew up the bacteria, and you make these little proteins, which are called antigens, okay? And then the macrophages actually present the antigens on the surface of the cell, right? That's the way that the immune system teaches the other parts, the white cells, the rest of the white cells, the T cells, what's bad, even though it's never seen it before. And so that's this slide. So if you have an infected cell and they put proteins on the surface, once the T cells identify these proteins as abnormal, it will recognize this combination, and next time it sees this combination, it's going to attack that cell, right? With the bacteria here, this is this thing going on here. So you come in, you ingest it, you chew it up, you find these little fragments, and you present it to a T cell, a T helper cell. And what happens is this T helper cell learns, anytime we see that again, we know we need to kill that. So this here is the end result of the start process here. And that's how our immune system learns. You encounter it, you try to break it down, and you find different ways, different proteins that you need to identify. So the immune system itself has multiple organs that are associated with it. Most people know about their tonsils and adenoids. Why? Because they flare up from time to time. But they flare up from time to time because they're constantly being bombarded with new things they need to learn about, right? And then you have your thymus, which is where the T cells go through an education process. So we're going to go a little deeper in that as we go further along. Everybody knows about the lymph nodes that they have underneath their arm, their spleens, even their appendix, and most importantly, the bone marrow, where all our immune system cells are born, right? Okay. And so these neutrophils, which are white cells, oh, this is in the way, but anyway, they basically, that's the way the body learns and presents. And when we look in a microscope, we can actually see these are red blood cells, but this is a neutrophil itself, and it's probably ingesting a bacteria, and once it's ingested, it's going to digest it and put these proteins so that when the immune system sees it again, everybody knows we need to attack this bacteria. And this was what it looked like under an electron microscope. So. All right, so the smarter guys in the group are these T helper cells, or these T cells. So they need to learn, but they need somebody to show them what's bad. And they learn by interacting with these receptors. So let's say you have a disease cell here. What the T cell is looking for is, you know what? Are the proteins on the surface of the cell anybody that we're looking for? If it is, then we're going to attack. If it's not, then we won't. And so killer T cells, this cartoon says this, if they see somebody that's virally infected, they're going to want to attack them. If they see somebody that has bacteria on the inside of the cell, their job is to attack. And even if they see cancer cells, their job is to attack, right? And actually, this is an electron microscope of a T cell attacking a cancer cell. So we know that this happens, right? Everybody good? So everybody got the T cells, the antibodies, everybody's good. Okay. This washes out a little bit, but this is actually a slide of a prostate cancer when we look at it under a microscope. The little red dots you see here are actually T cells that have come into the prostate cancer. So the immune system, without any prompting, has figured out that this prostate cancer is abnormal and needs to be removed. All right? So the big question then is that, well, if the immune system already knows that these cells shouldn't be there, then why is it not doing anything? And why are the cancer cells still growing? And more importantly, why do people like you exist to give chemotherapy if the immune system should be taking care of this, right? So we've known this for about 50 years. And so what we've done is we've actually come up with different ways to stimulate the immune system. Now this cartoon shows the sort of a life cycle. So let's say you have cancer cells, and remember the cancer cells die, so they release those proteins. Once those proteins are released, those cells pick them up and then present them to the T cells. And once the T cells recognize them as foreign, they call other T cells in and say, hey, we found somebody that's foreign. These are what we need to look for. And so those T cells come and they get out of the bloodstream and they go looking for these cancer cells. They recognize the protein again. And then what they should be doing is they should be killing the cancer cells, right? But we all know, for whatever reason, that happens, but it doesn't happen very well. And this is why. So when I was in medical school, which is now embarrassing, a long time ago, we didn't even know about this stuff. So we knew about this whole antigen-presenting cell with the T cell. We also know the T cells saw cancer cells as foreign. What we didn't know was this part, this PD, which stands for programmed death, right? So what happens is that cancer cells, even though they may have the protein that the T cell can pick up, they have a way of shutting down the whole process. So they have an off switch. And what they do is they hit the off switch, which causes the T cell, this should say T cell extinction, which causes the T cell to go off and die. And that's why in that slide we saw the cells that showed up, but they weren't doing anything because this portion was activated. And those cells over time the T cells would just die and the cancer cells would continue to grow. All right? Now, the real part of this talk is that now we figured out, if we can block the cancer cells being able to hit the kill switch, then the T cell will actually go off and start doing its job. All right? So, why is this so important? This mechanism right here, this ability to shut this cell down. Well, it has to do with something called immune tolerance, right? And basically, it's when somebody sees a protein, an antigen, but they don't respond to it, all right? Now, this becomes important because it affects the ability to to distinguish between our own cells and normal and abnormal, or own tissue and abnormal cells. All right, and how does the immune system do this? This is just another cartoon. If it's a self-antigen, if it's a non-self antigen, then the T cell will activate. But when the T cell binds, it's not going to bind that one, but it's going to look for a self-antigen. And if a self-antigen is present, then it will stop. All right? Now what happens, so why does the immune system recognize cancer cells as bad? Like I said, when I was in medical school, we weren't quite sure. We didn't even know. Okay? This stuff has only been the last 4 or 5 years we've been able to figure this stuff out. So it's all about the body's ability to recognize self. Okay? If the immune system isn't turned on by the antigen-presenting cells, the T cells won't attack it. So how do you get the immune system to turn on? I've already sort of given you a little bit of a preview, but there's different ways we can do it, right? First of all, by giving antibodies, which are the proteins that tag onto the surface of the cell, you can teach the immune cells, hey, go and attack those cells. You can teach T cells, once they learn it, they develop a memory to the cancer antigen and continue to attack cells. And this one is what people do with these quote-unquote cancer vaccines. They try to get our T cells to remember these proteins. Therefore, anytime they see these proteins, they'll go and attack that cell. So this cartoon says, now, if you're not properly educated, you will be negatively selected. Why is that? Anybody can think about it? Right. So you don't go on to attack yourself. So what happens when cells don't learn this properly? This is what happens. We get autoimmune diseases, right? We got lupus, right? This is actually a joint from rheumatoid arthritis, and this is another disease called scleroderma. So now you can imagine we have an immune system that's out of control, right? But an immune system that we obviously need. So how do you stop the cells from attacking normal tissue and destroying it, right? Well, in this case of lupus, this is just a rash on the face, but lupus can attack kidneys, lungs, heart muscle, basically anywhere. And scleroderma is more the skin itself. So that's a delicate balance. And that's actually an entire field unto itself. And that's actually the field of rheumatology. So people like me don't even get involved because we're not quite sure how to get that balance. All right? And actually, luckily for us, we have another rheumatologist back. We have Dr. Parker, who's with us tonight, who's sitting here. So that would be the kind of guy that you would need to see for an autoimmune disease, right? All right. So let's talk about types of cancer immunotherapy that we're going to do. So everybody knows about cancer vaccines. Now we have a better idea. You have proteins, you ground up, you show it to T cells. But the problem with cancer vaccines, the reason why you hear about them and then they lose favor is they'll only recognize the proteins that you show to the T cells. And if your cancer doesn't have those proteins on the surface, it doesn't work. All right? Then we have non-specific immunotherapies. And the reason why I say non-specific immunotherapies is basically what we knew in the 70s and 80s was that we can give proteins called cytokines, which will rev up our immune system to get going. And initially, you'll get a response, but then it would stop. And that's because we didn't know about the programmed death and the ability of the immune system to shut itself off. All right? We can enhance the immune system with these proteins, but rev it up. So then we can come up with monoclonal antibodies, which are proteins, which are man-made versions of the same proteins that would find bacteria. And lastly, and most recently, we have stuff called immune checkpoint inhibitors, which is that whole balance between self and non-self and how cancer cells kind of get around that. So, cancer vaccines. Everybody's heard about it. You know, you get cancer cells released from different patients. They irradiate the cancer cells. They extract the DNA. They extract the protein. And basically, patients will get either the cancer cells themselves that have been killed, or they'd get protein products of the cancer cells. And basically, that's a way to enhance your immune system. All right? And all you're doing is trying to improve your immune response. Okay? Now, you can get an immune reaction against the vaccine if the proteins are there, but not necessarily cancer. So think about it. If the proteins that you're looking for are inside the cell, your immune system would never see them. Right? You have different proteins that you're looking for different tumor types. So that's why one vaccine will never cover everybody. Right? Now, the immune system can actually mainly recognize what we call neoantigens, which are new proteins it's never seen before. But from what we call passenger mutations or shared antigens, which are basically a protein that's on the surface of a normal cell that looks similar to what the cancer cells produce it. That's harder for the immune system to see. Because remember, you don't want to start attacking yourself. Right? Most immunoresponsive tumors are what we call auto-vaccinated, but the immune system regulation, that's what I was talking about, gets shut down. Okay? So at the end of it, and I know I'm going to cause some stress for a lot of people, vaccines are probably unlikely to have a major effect in absence of something, that immune checkpoint inhibitor. They're never really going to get anywhere. And over the years, it's panned out. People get initially excited, and then it goes away. So the nonspecific therapies don't necessarily target the cancer cells, but you're just amping up the immune system. So they're generally used to enhance the response, and these are the cytokines and interferons and interleukins. Now, interestingly enough, in Dr. Parker's field, what they're doing now is, instead of killing the immune cells like we used to do when I was in residency, so just tamp down the whole immune system. If you don't have any white cells to fight it, you can't really have an immune response. What they're doing now is they're targeting the proteins that are stimulating the immune system. And so that's a lot of new drugs, and also modifying the immune system itself. All right, so this is a slide basically showing what we call adaptive humoral immunity. And these are the proteins that the B cells would make. And once you match up to the protein that you're looking for, then it sticks. And these are the flags that we're looking for. Now, if you don't match up, the protein just bumps along and keeps going along. So stuff that's stuck to the surface means that the immune system will come along and fight it. So those things are called antibodies. So the advent of monoclonal antibodies for us has been probably a 10 or 15 year experience now. There are hundreds of monoclonal antibodies. This is such a good concept that people have produced more and more of them, right? So we've used them a long time in cancer medicine, but now they're using them, like I said, in rheumatology, which is autoimmune diseases. There's some use in Alzheimer's, diabetes, even high cholesterol. We've been using them in the Bahamas for a while. So, and we've used them as part of the standard of care for many diseases and cancer types. The first monoclonal antibody was marketed was a medication called rituximab in 1997. I can tell you soon thereafter we were using them in the Bahamas. All right. In 1998, another monoclonal antibody for breast cancer was developed. Right? And we've been using that here also for a while. And it literally revolutionized the disease. Because now we didn't just have to poison the cancer cell. We could put this big protein flag on it and tell the immune system, wherever you see that protein flag, go kill it. Wow. All right? And so this is the way, this is the protein that that protein in the cell that the antibody is looking for. Once that antibody binds, then your own immune system comes in and activates and then looks to destroy that cell. So the first one of them was called Herceptin, or trastuzumab. The next iteration of it was a medication called Perjeta, or pertuzumab, and I'll show you that one next. And now we're up to another one called Kadcyla, which is even a more unique protein that we in this. And I'll explain that one when we get to it. Does this stuff matter? Does turning on the immune system matters? Well, this slide shows conclusively that it does. So if you see this yellow line right here, so these are women who have stage 4 breast cancer. This is their survival curve if we just give chemotherapy by itself. All right? And those are HER2 negative. These are women who are HER2 positive, but we don't give any of the Herceptin, right? So this is survival curve. So if you look at 12 months, at 12 months, if we use Herceptin, that protein, and we use the immune system in conjunction with chemotherapy, this is the difference between who's alive and who's not alive. It's quite a difference. If you go to 2 years, you can see quite easily that you'd rather be on this curve than on this curve. And these are people with stage 4 breast cancer. They're not curable, right? We know that their breast cancer will eventually overcome them, but they're very treatable, right? And so even if you come out, 48 months or 5 years, you still see that almost a quarter of women will be alive, whereas almost less than 10%, well, almost 10% would not be alive. But it's actually changed the life expectancy of somebody with this breast cancer, with this type of breast cancer, the HER2 positive. So at year 2, if you had no Herceptin, you had less than a 50% chance of being alive, as opposed to a 60% chance of being alive. Most people will take the med to do that, right? This next antibody is the pertuzumab I showed you, and this is the protein that it's looking for. So the trastuzumab binds to one site, and the other one binds to the second site. And it actually inhibits a couple of things from happening. So I put this slide in because this is an important slide for us in the Bahamas. So if you use, this is the Cleopatra trial. So if you use these 2 drugs together, it turns out that you survive a lot longer than if you use just the Herceptin alone, or trastuzumab alone. Why is this an important trial for this? Because actually we participated in this trial in the Bahamas. And this was one of the practice-changing trials around the world. So you had women on both of these drugs in the Bahamas here. All right. So actually, I'm pretty proud of this. Cause this was, let's see, we started this like maybe 4 years ago. The trial ran for about 2 years. And this is actually the published results now coming out. But we were part of a worldwide trial on this. Now, the last one that I said to come back to is the Kadcyla, which is kind of a cool concept. So you know that the protein sticks to the surface of the cell once it sees the antigen. But if it sticks and no immune cell comes on, what the cell tries to do is get rid of it, so it pulls it inside the cell. But when it comes inside the cell, what happens is there's a chemotherapy attached. The chemotherapy isn't activated until it gets inside the cell. And once it's inside the cell, the bonds get cleaved and the chemotherapy is activated. So it's kind of a very cool concept. It is a Trojan horse. It looks benign to the cell on the surface, but once it gets in, it becomes active and kills the cell from within. So it's actually theoretically less toxic than any other type of therapy that we could use. So we talked about breast cancer. We also are doing the same thing in colon cancers. So there's actually a couple of monoclonal antibodies that we're using. There's one called cetuximab, the other one called Vectibix, and these are antibodies against a receptor on the surface of the cells, EGFR. Avastin binds to another protein called vascular endothelial growth factor. The reason why that is important is because that's how cancer cells bring new blood cells. So most of these proteins are IV, so they go in IV, but some of the other therapies are actually becoming oral, they're pills. Okay. So Avastin, which is a protein, what it does is it actually stops new blood vessel development. So as cancer cells grow, just like everything else, if you grow, you need water, you need food, you need air. You get them from your blood vessel, right? But if you were able to slow down or stop the development of new blood vessels, you theoretically could slow down the growth of the cancer cells. And so we know that if we give this to existing tumor, we see regression of the blood vessels. We also know that new blood vessel growth is inhibited. So if the cancer cells keep growing, but they're not getting any new blood vessels, then the new cells are going to die off. And we also see that the surviving vasculature is not that permeable. It doesn't let stuff out anymore. All right. So these are great concepts, but what you really want to know is, does it make people live longer? And what this slide is showing is, the short answer is yes, it does. All right. So let's go on to the new thing that we were talking about, which is called this immune checkpoint inhibitor. Everybody's seen this slide already, right? So if you're tuning in for this at home later on, you're going to have to catch this lecture to start, because this won't make sense to you now. All right. So remember this PD-1? The tumor cell comes and cuts it off, right? But if we can block it, this T cell will definitely come and keep going and try to kill the cancer cells, right? So this is a cartoon which basically talks about PD-1. And this is a cancer cell trying to hit that switch. And the antibody that we're given is just blocking that switch. It's not poisoning the cell. It's not trying to get into the cell. All it's doing is stopping the cancer cell from being able to stop the immune system from working. All right? And the reason for the switch is the way cancer cells, quote unquote, hide their true identity from the immune system. And that goes back to the slide I showed you about the prostate cancer cell. The immune system showed up, but it wasn't doing anything because it was being masked, okay? So basically we're back to the protein again. So now he's here. He got everybody held up, but you want him to actually fire. But he's not firing, so how do you get him to fire? So this cartoon is a little busy, but these are the way a dendritic cell sort of stimulates a resting T cell, and once it sees the signal, it should go on and attack this tissue, right? But if this PD-1 happens, it doesn't happen. So it's the protein from the tissue that the dendritic cell was showing. So it's saying, hey, you need to go and fight this guy, right? But this is what's stopping the process, all right? So I put this slide up because, and it's not looking great, but this is melanoma, all right? So this is different stages of melanoma. Melanoma is a skin cancer that goes deeper and deeper. It's also one of the cancers that's always given us fits. Why? Because it's not very responsive to chemotherapy at all. And if anybody in here has known anybody with melanoma, they know it just keeps going and nothing seems to work with it. It's one of the first cancers where, by blocking this inhibition, we were able to get the immune system to go and finish its job and kill the cancer cells. This is a cartoon of kidney cancers. Also a cancer that doesn't respond very well to chemotherapy at all. All right? And the therapy for kidney cancers has always been to give a medication that stimulates the immune system to work harder. So it was one of those non-specific immunotherapies. So we used a medication called interferon, which Dr. Parker knows about quite well, and interleukin-2, basically to get the immune system to say, hey, we know you guys show up to these tumors, but do something. And even with higher doses, what generally happened is only about 5% or less of the people responded. Everybody else's immune system didn't do much of anything. So this is one of the newer medications that's come along. This is called Yervoy or ipilimumab. And what it basically does is that receptor that turns off the T cell, you block it. Therefore, the antigen-presenting cell can actually accelerate T cell production. So like everything else in life, these are all very good theoretical, but does this crap work in real life? So this is a CAT scan of somebody's lungs, and this is a tumor right here, okay? This is their heart, and this is the lungs right here. So this is pre-treatment. Post-treatment, you see the tumor nodule is gone. This is not chemotherapy. This is just blocking the immune system's ability to hide from the, it's blocking the cancer cell's ability to hide from the immune system. That's all they did. Down here, you'll see again these little arrows are showing these spots. After treatment, they're all gone. Now this is a cross-section of somebody's brain, and this is a tumor nodule in their brain. So they just basically blocked the cancer cell's ability to see the tumor, and it's now gone. The really cool thing about our immune system is it can go anywhere. So unlike chemotherapy, those cells can get out of the bloodstream and go anywhere they want to go. So even if you have a tumor at the very tip of your toe, your immune system is around, and it can go there and fight. So that's the fantastic thing about using immunotherapy. Once you teach the cells what to look for, they can go and fight anywhere. All right? So basically, this is a phase 3 study that actually got this drug approved in melanoma. But you see the difference in survival in years? There's no comparison. People with this is actually what we call a practice-changing event. Like, you know, somebody has melanoma, these are the drugs that we look to put them on. We don't even try with the other stuff much anymore. But like everything else in life, there's a price to pay. When you turn the immune system on, you turn it on everywhere. So you don't just turn it on to fight cancer cells, you turn it on everywhere. So anything that looks a little sketchy for the immune system, it's going to attack. So the toxicity associated with immunotherapy, dermatitis, so this is actually white cells kind of infiltrating the skin. Colitis, which is basically, so this is in the bowels, these are white cells getting into the bowels, and it can get pretty severe. And actually, you can get a hepatitis as well, which is an inflammation of the liver. It's not an infection, it's your immune system going after anything that looks funny. All right? So just like any other medication, there's going to be side effects, and they can get pretty bad. This Keytruda is a newer medication basically that blocks, once again, this PD-1. In order to treat cancer, we're coming to the realization that it needs to be a multi-step, multifocal thing. There's not going to be any one thing that's going to be able to do it all on its own. All right? So you're going to need a little bit of chemotherapy. You're going to need a little bit of antibody therapy. You're going to need a little bit of immunotherapy. Because remember, the cancer cells are alive, and they adjust to everything that you're doing. And they try to find ways to stay alive. And on that, I guess I'll end.
You've been watching Doctors Hospital Distinguished Lecture Series, presented every third Thursday in the month. Thank you for joining us.